Good morning, everybody. Morning and welcome. Thank you for joining us today. We're very pleased to have you here for this session on burnout, aggression, and workload in healthcare and aged care sectors, areas that we know are very much front of mind for many of you right now. My name's Krisha Hunt. I'm the principal consultant here at AP Psychology and Consulting Services, and I'm joined by Mariana Margevka, who's the Injury Partnership Manager at DXC Claims Management Services. She's a registered physiotherapist with more than 20 years of experience in injury management, workers' comp, and workplace health and well-being. We've also got Josh Marsden on the call today from AP, who will be assisting the running of the webinar this morning, and will be running some polls throughout the session, and we'll provide you with some post-session insights as well after today's session. So over the next 60 minutes, we're going to explore what the most common hazards in health and aged care are, what the early warning signs of burnout and overload look like. And Mariana is going to take us through the latest workers' compensation trends, helping to paint a picture of the pressures and the emerging risks that are shaping today's workforce. We'll also walk through a clear best practice approach to managing risks and look at why prevention's better than cure, as well as sharing some practical real world examples as well. If we have time, hopefully we'll get a little bit of Q&A at the end as well. Just a little bit about AP Psychology and Consulting Services. We've been working for 16 years in this field, looking at how to help people thrive and help people be the best versions of themselves at work. We're a bit ahead of the curve in terms of looking at this, setting our Arthur Papagiannis, our CEO and founder, set this up 16 years ago. And this is our bread and butter. So looking at assessing workplaces in terms of their psychological health and safety and looking at the risks that are prevalent in workplaces. We've actually done over 200 risk assessments in the last financial year through our Mentally Healthy Workplaces program, which is supported by WorkSafe Victoria. So lots of expertise, and hopefully we can share some of that with you today. So looking at what psychological health and safety is and what a psychologically healthy and safe workplace looks like, it's really an environment that promotes employee mental health and well-being, prevents work-related harm, and supports recovery from mental injury. It's defined as a workplace where hazards to mental health are managed in the same way as physical hazards. So that's by identifying, assessing, and eliminating or controlling risks. So it's very similar to the way that we manage physical health. We need to understand what the environment is that we're operating in. We need to understand what the risks are that are posed to our workplace and our workforce. And we need to have a good idea of how we're managing those and do that in as proactive way as we possibly can. There are lots of psychosocial hazards that can potentially pose a threat to the mental health and well-being of our workforces. And the list that you can see on the screen there is from WorkSafe Australia, and they're managing psychosocial hazards at work code of practice, which was published back in 2022. And as you can see, there's a number of different factors or hazards that can pose a risk to people's mental health and well-being, including things like high job demands, violence and aggression, having low control in the work that you do, not having a lot of input into decisions that get made, etc. So what we want to do is be able to understand which of these hazards are really more prevalent, particularly in healthcare and aged care, and how do we start to manage those? How do we start to reduce the likelihood of them happening in the first place or the impact of them if they do occur? We know that if we don't do this, if we don't look at how we manage and how we control for those risks and those hazards, we know that there is a significant impact, not just for organizations, but also for individuals as well. So we know that if we don't look at this and if we don't look at this in a proactive way, ultimately the impact on individuals is that people get burnt out. People might start to experience psychological conditions such as anxiety and depression. We also notice that people will experience mental health symptoms, so things like fatigue, sleep disturbances, possibly changes in eating habits, all of those kinds of things. And we also know that there is a lowering of cognitive function as well, because when we're stressed, when we're not being the best version of ourselves because of the impact of those hazards, we know that we're not able to make decisions as effectively or quickly as well. So there's a huge impact on individuals and obviously also then their families and the people that they work with, etc. There's also an impact, of course, on the organisation as well. So if we've got those hazards that are not being well controlled, you're likely to see impacts in terms of things like increased absenteeism, increased staff turnover, lowered productivity and performance, but also then additional kind of flow-on impacts as well. So things like increased recruitment costs because of that turnover. You may see increased claims as well. And ultimately, of course, as well in health and aged care, we're also looking at a potential impact of the decrease of quality of care and safety outcomes as well. So there's lots of reasons why we want to look at how we control these hazards, both from an organizational perspective and from an individual perspective as well. And we know that those early signs of people starting to struggle are things in changes in their behavior. So things like not turning up for work on time, looking like they are struggling with workload, not necessarily getting on with their colleagues in the same way that they're used to. So lots of those warning signs that we can pick up on as well. So that's just a brief introduction to psychological health and safety and what that looks like in the workplace. What I'm going to do now is hand over to Mariana to do a deeper dive into workers' compensation trends in healthcare and aged care. And then we're going to come back and look at the best practice in terms of managing some of those hazards. So thank you, Mariana. I will hand over to you.
Good morning, everyone, and thank you to Krisha and AP Psychology for the opportunity to join you today. It is a privilege to be here on behalf of DXC to discuss this increasingly important topic across the health and aged care sectors. At DXC Claims Management in Victoria, we manage a large portfolio of and volume of claims in these industries, giving us a strong insight into the data, trends, and risk factors shaping workers' experiences. We understand the unique environments and pressures in these environments and factor them into our early engagement and return to work strategies and overall claims management approach. I can't wait to take a deep dive into the data insights with you to unpack why understanding these plays a vital role in preventing risk, driving early intervention, and supporting a safe and sustainable recovery. Thank you again for having me. Okay, let's get started. I'd like for you to pause for a moment and just really take in this colossal representation and sheer scale of Australia's health landscape. This is from Australian Government, Department of Health, Disability and Ageing. Okay. Health and aged care is now the largest and fastest growing workforce and sadly, one of the most injured. Right now in Victoria, someone working in health or aged care is injured seriously enough to lodge a claim roughly about every 20 minutes. As an allied health professional myself, being a physiotherapist who worked in both healthcare and aged care sectors, this is close to my heart. And I understand, and the team behind me at DXC understand that behind every number, there is a worker, a team, and a service under pressure. So let's look at what the data is really telling us. We've mentioned that our health and aged care is the fastest growing major industry, and there's actually strong projected growth through to 2034. Median worker age is 40, with 76% being female. But what is really significant is that 43% of the workforce is actually part-time, with multiple job holdings increasing. When we look at labour demand, it's a high industry. We know that there's ongoing demand for extended service coverage, shift work, overtime, agency workers, and employers are reliant also on migrant workers and students, which impacts continuity of care and workforce stability. Research actually indicates that over 1 in 10 practitioners are considering leaving their jobs, with mental burnout cited as major factor. Why? What are the structural drivers? We know there's aging population, NDIS and home care expansion, chronic disease burden in Australia, and workforce shortages in nursing and aged care. I'll quickly touch on the pay pressure. It is significant that in the health and aged care sector, the earnings are below all industry average, and this can also reflect the part-time and lower paid care roles. Okay, next, please. All right, so we'll take a deep dive into our DXC data, and we've looked at a large volume of our health and aged care clients to pull this data analysis for you. it is interesting that 73% are actually made up of physical injuries, so manual handling, falls, slips and trips, and being hit by moving objects. And it is a major cost driver. In saying that, whilst musculoskeletal injuries are high for frontline workers, psychological injuries are in top three. And you can see that, from 17%, there's actually reflective and comparatively higher claim costs being 23%. Psychosocial risk is higher at senior management level, who are having to navigate workforce demands and challenges. And, majority of the 73% of the physical injuries. Burnout, fatigue, and resourcing factors do play an important part, increasing injury risk and reducing safety compliance. Surprisingly, there is actually no single nationally published secondary mental injury rate specific to healthcare in Australia. The best available benchmark is by WorkCover Queensland, that shows that around 5% of physical injuries with time off can become secondary MI claims. And drumroll, this has actually doubled in the last 5 years. We know that even at 5% return to work, 5% secondary MI rate, return to work rate drops, and it's as high as by 25 to 30%. So, if you add 5% to 73% of the physical injuries, this is, huge burden on the workforce, but also the claim cost and premium drivers. Aging workforce injuries are also important to consider. With over 50 years of age, the injury rate increases. When we look at this slide, the orange part really stands out, and it's 64% of injuries occur due to other person, which indicates patient handling, OVA, being the leading injury risk contributing factors and driving the highest claim cost, being 70%. So attention and focus is required to safety awareness, OVA control, and robust injury prevention, early intervention strategies to navigate these huge statistics. When we look at return to work rates, and at DXC, we understand the industry injury risk and profile and mindful of key barriers to recovery that drives the key recovery drivers for managing claims. You can see that in the first 12 months, quite even representation of full return to work, partial return to work, and no return to work. Have a lost time claims, lost time injuries drive the highest claim cost, being 65%. The first year is the critical window to influence recovery and claim outcomes, particularly, with your back at work recovery at 16 weeks and 26 weeks to reduce pressure, reduce claim costs, but also reduce the risk of the secondary MI that we spoke about earlier. When we look at return to work overall, with sustained support, return to work does improve to about 77% long term. And we do see that most workers in healthcare and aged care do want to return to work when supported by suitable duties and clear pathways. So this is a strategic advantage when structured well. This slide, so at the top, you've got the highlights of the data we spoke about, the burnout, fatigue, driving the injury risk, the physical claims, and also considering impact of secondary psychological claims, 69% return to work rate within the first 12 months, lost time claim drivers been 65%, and aging workforce. So what are the key risks driving the injury rates? Psychosocial hazards such as high workload, low job control and emotional strain, occupational violence and aggression, particularly in those emergency settings, mental health and aged care, fatigue and shift work impacts, including extended hours and irregular rosters, hazardous manual task, lifting, patient handling, transferring patients, and inexperience and rapid onboarding, especially in high turnover environments. So have a look at your part-time and agency workforce and your induction and safety awareness training to try and control this part of what makes up the claim injury and claim cost. Why high workforce demand due to aging demographics? We spoke about that at the beginning. Strong employment growth, high reliance on part-time and shift-based work, contributing to fatigue and injury exposure, and also increasing complexity of care, particularly in aged care and disability support, raising both physical and psychosocial risk factors. So what can we do to navigate and reduce injury risk? Requires a combination of system level and workplace level strategies by embedding your psychosocial risk management that is aligned to psychological health regulations, investing in violence prevention programs, including de-escalation training and environmental controls, strengthening your safe handling systems, improving staffing stability, building capability in early intervention. And again, this is critical at pre-claim, at early claim and early engagement, return to work, building, enhancing your return to work planning with clear communication, being very creative with your suitable duties as well. And these approaches align, and I can speak only for WorkSafe Victoria, but they do align with a strategy to improve return to work rates by 10%. How? Early support, investing in targeted, creative and tailored education and training, designing meaningful, suitable duties, and collaborative work design and return to work planning solutions. If you'd like to find out more information about DXE, please reach out. We'd love to help. If you've got any more questions about the data insights, we can help you with that as well. That is it from me, and I'll be around to the end to answer any questions you may have. Thank you for having me.
Thank you so much, Mariana. That was really helpful and interesting insight and that deep dive into the current landscape. And as you were describing there, the impact of uncontrolled psychosocial hazards is really really obvious. So we've got 64% of claims being due to interactions with other people, whether that be external service users or potentially internal co-workers, and we've got 70% of claim costs as well being related to those interpersonal hazards as well. And that brings us back to looking at, well, what are the most common hazards that aged care and healthcare workers face into? And what we've done here is to just in bold highlight those ones that are typically more common in this sector. So we absolutely know, and I won't be saying anything that you don't already know. We absolutely know that in this sector, too high job demands is a critical hazard. So people doing more with less, people needing to potentially backfill in roles, working with less than optimal tools, equipment, etc. We know that there is a huge amount around job demands, but job demands isn't just about how much time you've got to do a particular task or the equipment or the training that you've had to be able to do that. It is also about the emotional load that goes into the work that the workforce does. And obviously with healthcare and aged care, that emotional load is significantly high and significantly different to a lot of other industries. So we're in a people orientated sector, and absolutely there are more demands placed on people in terms of being invested emotionally in the work that they do. And that crosses over as well with some of those other common hazards that we can see that are highlighted there as well. So of course, in terms of healthcare and aged care, people are more exposed to traumatic events or materials compared to other industries. We absolutely know that. And that's one of those things that perhaps we can't necessarily have as much control over as we can with other hazards. So that's an inherent hazard within the role, that we will be exposed to that trauma and those events and materials. But what we then need to do is kind of say, well, how can we buffer that then? How can we make sure that we are doing as much as we can to support people when they are exposed to that? We know that exposure to violence and aggression certainly being higher in this sector as well. So frequency rate of serious claims being due to people being assaulted by a person or persons is 6.5 times higher compared to other occupations. So that exposure to violence and aggression is absolutely a reality and a key hazard that this workforce faces into. And we also know that those internal conflicts as well, or the poor workplace relations interactions, absolutely play a part. And this often can be because of some of the existence of some of the other hazards. So the fact that we've got a workforce who is working very hard in a very emotionally draining role, where there is limited resources, where they are exposed to trauma and traumatic events and materials, that then actually means that we have a little bit less kind of bandwidth to be the best versions of ourselves. And so that can actually then cause conflict and poor interpersonal relationships, because people are stressed and people are trying to do the best that they can in the circumstances that they're operating in. That the extreme of that is then looking at things like bullying and harassment. So rather than just low-level conflict, which may be resolved, that can then turn into things that are much more serious in nature around sexual harassment and bullying as well. So, we know that particularly from the People at Work survey in 2024 showed that workers in healthcare and social assistance industries were more likely to report bullying in the workplace. So that was 31% compared to 29% across all industries, and much more likely to experience workplace violence, so physically aggressive people, at least once a month. Compared to almost never for other industries. So the frequency of the exposure to these hazards is significantly different as well. Also, that People at Work survey report showed that angry or hostile behaviour was experienced 50% of time compared to 41% across all other industries. And that's things including like shouting and swearing, intimidation and insults. All of those things are much more prevalent in this area compared to other industries. So going back to what I mentioned earlier around, the impact of, if we don't manage these hazards, absolutely there will be an impact on the individuals, but on the organizations as well that people work in. So what do we do? How do we manage this profile of risks that healthcare and aged care has got? So we're going to spend a little bit of time now looking at what the best way forward is, and what you can do to start to think about, how do we approach this? How do we make sure that we are protecting and supporting our workforce as best as possible? So the first thing to think about is considering the recent changes in legislation. Victoria was the most recent state to join the rest of the states and territories in having a code of compliance or code of conduct, a code of controls around how to manage psychosocial risks. However, all states and territories look very similar in terms of these sort of 4 steps around how to approach psychosocial risk management. So the first step is around identifying the hazards. So identifying what are the things that are impacting on our staff, what is our risk profile. And a lot of that work has already been done by the regulators. So that list that I was just showing you before from Safe Work, that's identifying, well, we know that these hazards exist, we know that these are common hazards, and we know that there's certain hazards within this industry that are more prevalent than others. So that step 1 has been done to a large extent. However, we absolutely recommend that you also look to your own workplace, your own organisation, as there might be things that are different from other organisations that are even in a similar sector and industry. So identifying what those hazards are, then assessing the risks. So that's things like looking at, how do we understand what the level of exposure is? So how often are people exposed to those hazards? What's the frequency? What's the duration? And what's the likely impact of that if we don't control it? Step three is then controlling those risks. So what do we do to either eliminate or reduce the impact of the risk? If it's not practical, reasonably practicable to eliminate the risks, then reducing them is the best way forward. And this can come in lots of different shapes and sizes, and we'll talk about some of the best practice around control mechanisms in a moment as well. Crucially, the step four is reviewing the controls and the control measures as well. So this absolutely, psychosocial risk management is an ongoing process. It's a continuous improvement process. So there should always be a mechanism by which we can review what controls we've got in place, understand if they are working or not, and understand what kind of tweaks might need to be made, or if new controls need to be added to our battery of controls. In this risk management approach, though, there's two crucial elements, and you can see at the middle of that diagram there, leadership commitment is absolutely critical. And we know from working with a lot of organizations in this space that unless we've got that kind of really top-down commitment, then tackling psychosocial hazards can be more difficult. So it's really important that leadership, and we're talking sort of board level, CEO level, all the way down to every single people leader, understands the importance of psychosocial risk management, understands what psychosocial hazards are, understands what what the different roles and responsibilities are, and that we are absolutely committed to making sure that we're doing what we can to support and protect our workforces. So that leadership commitment is absolutely critical. It underpins all of those four steps. And equally important, on the outside of that diagram there, you can see consultation. So that's consultation with the workforce every step of the way. So we might be able to, as HSRs or as OHS reps, we might be able to understand what the hazards look like, but it's really important that we actually seek that information back from the workforce, from the people who are actually experiencing them as well. So understanding what are the things that are impacting you most, asking our workforce that so that we get a better understanding and we bring more sort of colour and life to what those hazards are and what the impacts of those hazards are on our workforces. So consulting to understand what the hazards are, consulting to understand what the impact is, but also critically as well, consulting to implement controls. So our workforces are the people who will be able to tell us if our controls are working or not. We might have a really great suite of policies, procedures and systems, but if they're not being executed on, if they're not being followed, then we're having a limited amount of effect. So we absolutely want to hear from the workforce as well, what's working, what's not working, and what might need to be added into the picture. So those four steps with the leadership commitment and consultation underpinning it are a great way to consider, what are the things that you are doing in your organizations already around being able to identify hazards, assess the risks, control the risks, and review the risks. In terms of actually looking at controls, though, there's a framework that we use, which will be fairly familiar to most of you as well, the Prevent, Protect, Support framework. And this provides a clear OHS-aligned framework for managing psychosocial hazards. So prevent includes things that are more proactive. So it's around things like managing workload, managing competing priorities, making sure that people are clear on what their roles are, giving decision-making authority, and also even things like embedding respectful behavior. So really trying to create an environment and a culture where respect is there, where people are clear on what they're doing. And so what we're trying to do there is really eliminate harm before it happens. Protect is obviously around more of the early identification and response to hazards and the impact that they might be having. So this might include things like reporting and escalation pathways, or having a fair response to complaints or incidents, making sure that we're having proactive management check-ins with staff as well, so we can get to hear early on if people are struggling or what the hazards are that are impacting on people. And it's also about helping our workforces build resilience and know what the strategies are to help themselves and help maintain their mental health and well-being as well, so they can navigate the stresses that they're exposed to. Support is that more sort of tertiary intervention. So obviously it's providing support if an injury or illness has occurred. This may be around return to work practices. And as Mariana was saying, we can see that the return to work levels vary quite a lot. So having processes in place, having leaders and having SMEs within your organization who can support really good robust return to work processes where there are reasonable adjustments being made to people's duties, those kinds of things. Those are the kinds of things that would fall into this support area. So support initiatives absolutely complement, but they don't replace effective hazard prevention and protection. And actually, we know that prevention is better than cure. So, making sure that we can get in early and prevent things means that we have better outcomes in the long run. So we know that if we're reactive, so if we're focusing just purely on that support area, we tend to see workers' compensation premiums going up. We tend to see that there are increased costs due to backfill because of turnover, etc., and because of absenteeism. We see that there is higher burnout, higher turnover, higher work shortages, and we also see that there's an increased clinical risk essentially as well. There's also things around reputational and regulatory risk as well under the legislation too. So there's good reason to look at proactive preventative measures. All three are important, prevention, protection, and support, but proactive prevention means that we can reduce the long duration of claims and the associated financial impact that can have, as Mariana was talking about. We know that it improves retention. We know that it also strengthens patient safety because we've got stable, engaged teams as well. So being able to take a really proactive approach is where a lot of the energy and resources should be targeted. So having a look at all three areas, absolutely, but looking at to make sure that you've got a spread of initiatives and controls that lie across three with a bit of an emphasis on those proactive, preventative measures as well. And we use a framework that helps organizations to make sure that that you have got a spread of controls across all of those three categories. So you can see there prevention, protection, support across the top. And AP Psychology and Consulting Services uses this framework that's actually been developed based on work that was done originally by the National Mental Health Commission and the Mentally Healthy Workplace Alliance back in 2014. So we're using that established framework of prevent, protect, support, but it further articulates 7 particular focus areas that all organizations can look at, which will help to control one or more of the hazards that we were seeing outlined on that table previously. So having a range of strategies across those 7 focus areas means that you're better placed as an organization to have a strong ecosystem of interventions and controls across all of those different hazards. So building leadership capability, you can see at the top there, actually goes across prevention, protection, and support. So that's where we've got leaders who are, again, understanding what psychosocial health and safety is, understanding what their role is, are confident to be able to interact with the workforce around psychosocial hazards and the controls necessary to make the workplace experience more stable and more positive for individuals. We also have increased awareness at the bottom, which again goes across prevention, protection, and support. So having a workforce more broadly who understands what is mental health at work, what does that look like? How do I take care of myself? Am I aware of what the supports are that are available to me through my organization in terms of my mental health and well-being? So having those sort of two focus areas that go across prevention, protection, and support are the great foundations that you can build in terms of the controls you've got in place. There's 5 then that sit in the middle there. So you can see that 2 are under prevention, and that's build better work cultures and smarter work design. 2 that sit under protection, so building resilience and coping skills and early intervention, and 1 that sits under support recovery as well. So in terms of prevention, we want to look at building better work cultures and looking at smarter work design as well, because we know that if we focus our energies and our attention on those 2 areas, it actually has a really solid flow down effect into all of the other areas as well. So on this slide, you can just see some examples of the kinds of controls or interventions that you might be able to put in place that are focused on those more preventative areas of building better work cultures and smarter work design as well. So we think about having a positive workplace culture. We know that that can do so much to buffer some of those stressors and some of those other hazards that people are experiencing. We know that a great workplace culture is critical to a healthy and safe workplace. So that means having policies and procedures that can support that. So things like codes of conduct, bullying and harassment policies, but also capable leaders who can intervene if they're seeing that there are people who are starting to have conflicts that are escalating. They know where to step in. They know what to do. They know that they can get support from HRBPs, for example. It's also things like allowing people to get to know one another as well. So not just on a work basis, but also on a more general interpersonal basis as well. So what are leaders doing to help build team culture and help build interpersonal relationships and strengthen interpersonal relationships? Because all of that goes into creating a better work culture. It's also around making sure that we recognize and reward positive supportive behavior, and also that we are recognizing and rewarding staff more broadly too. So where we know that in aged care and healthcare, people are often going above and beyond in terms of the work that they are doing, having formal and informal recognition and reward mechanisms is a really important part of building a better work culture where people feel seen, heard, valued. And these don't have to be big things. They're not about necessarily having a big monetary component. This can be more around how do people celebrate wins? How do people acknowledge one another in their teams? So all of these things seem small, but actually are all really good controls that help to support better work culture, which then flows into managing things like conflict, managing things like interpersonal problematic behavior, starts to also then impact even on things like work demands and job demands, because people actually are then better placed to understand what's happening and what people have on their radar and their different workloads and help each other out. So having those better work cultures is a really great way of making sure that we can have an impact on not just interpersonal relationships, but also some of those other hazards as well. Smarter work design is that second prevention area. So again, being able to have some controls that look at how we can design and work and the tasks that people do in a way that supports mental health and well-being rather than adds to the load. So it can be things like, making sure that, again, roles are clear, but also that escalation pathways are clearly defined. People know what they are. People feel that they can speak up and put their hand up if they're feeling that they are starting to become overwhelmed with work or that emotional load is becoming too heavy. Making sure that we've got support available and again, that people know what that support is, where to get that support, whether that's through their line leader or whether that's through more formal mechanisms like EAP, for example, as well. But also doing things like making sure we put in recovery time. So where we know that workload is high, what are we doing to make sure that people can take breaks and can actually take true breaks where they're not on call, where they're not responding to ad hoc requests, making sure that we're actually designing the workflow in a way that people get an opportunity to rest and recuperate. It's also things like making sure people use their annual leave, and plan for that as well, so that we plan what the workload will look like when different people are taking leave, and that is a proactive, planned approach rather than a reactive approach to when people are off sick or on unplanned leave. So there's small things that we can do within, structuring the roles, structuring our workload that can help people feel that they've got more support in that area. We can't necessarily remove exposure to illness. We can't necessarily remove exposure to trauma, but we can absolutely put in place a lot of smaller techniques and mechanisms to make sure that the impact of workload is lessened on people. And we've done this a lot with various clients that we work with. And I just want to spend the next few minutes just talking through some real world examples to bring it to life. So I'm going to look at what the challenges were that these organizations faced, and the practical steps that we took together to address them as well. And we'll explore how these organizations approached their psychosocial health and safety risk management and improved their worker experience. So let's move from theory to practice now and run through a few examples. So the first example was a national healthcare provider who had 40 sites and over 10,000 staff. So they were multi-state in terms of their presence. And they delivered acute and community-based care with high-risk clinical workforce operating under sustained system pressure. So the challenge for this organisation was that, and this was a couple of years ago that we started working with this organisation, that they understood the need to take a proactive approach and to have an approach to psychosocial hazard management. But at that particular time, they didn't have that practical approach. They didn't have the in-house expertise or capacity to act at the pace either that the board was actually requiring of them to say, what is our approach to psychosocial hazard management? What have we got in place? And what are the systems and processes that we're going to be using? So what we did was partner with this particular client, and we partner with all our clients to really try and co-design what the approach needed to be. And we engaged initially with executives and clinical leaders in particular, so that we could understand what the current picture was, but also so that we could share and raise awareness and knowledge in the executive team and in the clinical lead team as well, to increase their knowledge of psychological health and safety, so that they knew what we're talking about, what the hazards are, what the controls could look like, what an overarching approach could look like, so that when we actually then started to roll things out across the organization, the people who had accountability and responsibility for some of the actions, that there was senior leader support, senior leader knowledge around that. And that goes back to that model that we were talking to earlier, where that leadership support is so important for these initiatives to really work and be as effective as they can be. So a lot of time spent with the executives. We also then undertook a structured review of what already existed in the organization that was actually contributing to psychosocial hazard management. So most organizations will have a lot in place already, but it's not necessarily clearly mapped as a way of approaching psychosocial hazard management. It tends to be a little bit disconnected and not integrated. So we reviewed what was in place and looked at what the gaps were, and what could be improved there as well. And then we also conducted some practical training. So once we knew what needed to happen, and once we knew who all the stakeholders were that needed to be involved in the project, what was necessary for this organization to be able to be self-sustaining and to be able to carry forward psychosocial hazard management was really to improve that in-house capability. So what we did was work with the relevant people, which was including OHS teams, HSRs, but again, also some clinical leads as well, so that those people absolutely had the confidence and capability to identify hazards in their particular areas, be able to identify the controls that were already in place, but also assess how much those controls were working, how effectively those controls were working, identify any missing controls, and also then be able to understand and utilize a governance process that we'd put in place to be able to raise where there were issues, where controls weren't working, or where additional controls needed to be put in place, that there was actually a mechanism for people to be able to do that, and that was clear and that was consistent across the organization as well. So we built that internal capability through the practical training, and we built some risk assessment tools that were built specifically for that client, which allowed them to really embed those processes and really take a much more proactive approach, aligned with what the board wanted and also obviously what the legislation required as well. In terms of what that achieved for them, it meant that there was a much greater understanding and a shared understanding across the organization of what the risks were within their organization, but also across different sites and different sort of service units as well. So much more knowledge, much more awareness. But also that practical training meant that there was a lot more confidence in being able to identify hazards and then obviously being able to control and review as well. There was also then, much as a result of the project and the work that we did with the client, a clear and strong governance process as well. So being able to have reporting processes, having opportunities and forums where psychosocial hazard management was on the agenda, and having feedback loops so that those emerging issues, emerging challenges could be fed both upwards from on the ground teams up to committees and up to management and board, but also downwards as well. So being able to have that two-way feedback process was really important. So we were able to walk away from the client knowing that there was that internal capability and that client was well positioned to be able to continue on their psychosocial hazard management journey. And that's what it is. As we said, it's a continuous improvement process. So it's not a once and done. It's making sure that you've got that capability and the systems and the processes to support on an ongoing basis. Another client that we worked with as well was a national aged care and community services provider who delivered in-home care and residential care, again, across multiple locations. So they had a geographically dispersed and distributed workforce with high needs clients as well. So environment, again, of sustained demand and workforce pressures, as we know is the case in so many healthcare and aged care providers. And the challenge for this particular client was that there was a rise in occupational violence and aggression incidents. So again, in line absolutely with what we've been seeing in the stats and what we know are other common hazards in this area. There was also increased workload because of the increased complexity of cases as well, competing priorities from an operational point of view as well. And in this organization, similarly, a lack of understanding and lack of awareness and capability at a line leader level to manage psychosocial hazards and implement those controls. There was also a little bit of lack of consistency across different locations and different business units, as can often be the case where you've got large organizations that either have different business units or are geographically dispersed. So what we did with this client, again, partnering with them, co-designing with them, but looking at, again, what they had in place already. So what were the good things that were already happening within the organization, looking at their policies, their systems, their initiatives that were contributing to psychological health and safety. And then we consulted with a sort of key working group that we were working with to really sort of measure what the level of psychological health and safety maturity was within that organization. We also added to that by undertaking focus groups with a representative sample across the organization to understand what the experience of the actual staff was. As I was saying, that kind of, that outer circle that we saw in that model earlier, really to understand the experience and perceptions of staff and obtain examples of what things were impacting them and how they were impacting them as well, so that we could then create controls that were really meaningful, that could actually be implemented, that weren't sort of, theoretical in nature, something that actually is going to work on the ground. So we had a focus more on occupational violence and aggression with this particular client. And we ran training workshops related to psychological health and safety, but with a focus on OVA as well. Again, with the view to increase internal capability and allow the organization to be self-sustaining. And what we achieved through the various initiatives that we put in place with this client was Ultimately, there was a more coordinated organizational-wide OVA response, and a more proactive approach to it as well. And so things like having consistent, timely, effective support from capable leaders, so that every leader, no matter who I am in the organization, no matter who my leader is in the organization, I know that if I'm exposed to OVA, I'm going to get a similar response, and that my leader knows how to intervene, knows what support's available, and does that with a care-led approach rather than a task-led approach. We also supported this organisation to look at how they can prioritise some of the workload, because it was a complex environment and where there were a lot of competing operational demands. Sometimes that was leading to a lack of clarity around what priorities were. So we worked with the client as well so that leaders could be really clear in workload prioritization and assist their teams to be clear on what the focus was, and even things like giving allowing people to have a shift handover where not everything might have gotten done in the first shift, and that's okay, and but having a really clear shift handover process so that people were then not misunderstanding what was or wasn't done, understanding what their roles and responsibilities were, but creating a culture where there wasn't an expectation that one particular shift would get everything done and then the second shift would be a sort of mop up, actually changing the culture around that as well, which had a huge impact for that organization. The last client that I want to talk through was a Victorian-based client, so public health service, again, delivering acute and specialist care, multiple campuses, and again, obviously high risk and complex work, and fast-paced environment as well. So the challenge for this organisation was, particularly because it was Victorian based, was to make sure that they were aligned with the recent regulations, which came out 1st of December in Victoria last year, but also make sure that there was an executive level understanding of, again, what the current things that this organisation already had in place, because they were there, but there was a limited visibility around that. So having exec being really clear on that, but also then being able to sort of increase the visibility of those interventions and increase the visibility to the workforce of what was already being done to help protect mental health and well-being as well. So what we did with this particular client was actually use our workplace psychosocial safety index, which is a survey tool, which is run from our platform TM Thrive, which Josh Marsden, who I introduced earlier, manages. So that particular tool really focuses purely on psychosocial hazards. So it's a little bit different from, say, employee engagement surveys. It's really looking at those common hazards that we know exist and getting a read from staff on which of those are impacting most greatly. It really helps to establish a baseline of where the organisation was at and understand what the key hazards were that were impacting on their workforce. We backed that up again by using focus groups. So knowing what the risk profile looked like from the survey results, we were then able to talk to various groups across the organisation to understand that better, understand the experience better, and understand those perceptions a little better, with a view to creating solutions, again, that were realistic, implementable, and had value from the workforce's perspective as well. We also, again, undertook a bit of a review of everything, all the systems, the policies, procedures that were in place, and again looked at where those opportunities were to close any gaps that might have been there. And the impact for, the outcomes for this particular client was that by the end of this, there was a much clearer view of what their particular risk profile looked like. So knowing specifically what the hazards were, the priority hazards that were really impacting on staff. And also then having clarity on initiatives and the next steps to strengthen effective psychosocial risk management. So looking at those really priority hazards that were having the most impact, taking those first, because otherwise it can be really overwhelming to look at an entire psychosocial risk management approach and thinking, what do we do first? by understanding what the risk profile was for this particular organization, we could absolutely then target what the key areas, what the key first steps needed to be. It's not to say that other things aren't important, but it's being able to then do things in a stepwise approach so that the organization isn't overwhelmed by the amount of initiatives and controls that might need to be put in place. So doing that in a stepwise phased approach is another best practice mechanism as well. So as I mentioned at the beginning as well, this is our bread and butter, doing psychosocial hazard assessments, such as the one that we did with this Victorian Health Service. We do this day in, day out, every day. And as I mentioned, we've done sort of 200 or so of these in the last financial year and are set to do several hundred more in the coming year, and which is great so that we can really support organisations understand what their profile is and understand what the next steps might be for them as well. What the slide I'm just putting up now is one of those clients that I was just talking about was in fact St John of God Healthcare. And if you would like to scan the QR code to download the case study, then that will give you more detail on what we did with that client and what those outcomes were as well. So I'll just leave that up for a moment. Josh, I will also hand to you if there's any questions that have come up in the Q&A. We've got just a few minutes to be able to answer any questions that people might have as well.
Thank you, Krisha. Thank you, Mariana, for that presentation. It was fantastic to hear that fantastic insights, and we'll share all of those insights in the follow-up comms from the session. Particularly like how we are starting to bring together all of the data points. So the data points around the psychosocial risk assessment, the gap analysis, plus the workers' comp data. So working closely with DXC with clients so that we've got the whole picture, and we can actually show the outcomes as well. So there's a bit of a theme in the Q&A. So Krisha, how do we create a consultation process with frontline staff, HSRs, and work health and safety committees that is generally inclusive but remains focused on identifying realistic and effective controls rather than an open forum for grievances?
Yeah, that's something that came up with across all the clients that we work with as well, as like in terms of what is the focus of the focus groups, and that's where having a clear idea of what key priority hazards are to start with can really mean that you can absolutely focus those consultation sessions. So if, for example, you know that OVA has been increased, then you're getting a representative sample from across your organization, so frontline workers, frontline leaders, HSRs, and getting those groups mixed as well can be a really positive thing. So you're getting people are hearing different perspectives and hearing different insights as well, but posing the question of, we know that this is increasing, OVA is increasing in our organization. Tell us a little bit firstly around what this looks like for you. So what are you seeing? What are you experiencing? What does this look like in real life for you? And spending a few minutes exploring that, but absolutely moving that then to, okay, what have we got that works at the moment? What are the systems of support that we've got? What are the interventions that we've got that are working? And tell us what's not working as well, because we want to improve this and we want your input because you are the people who will be experiencing the controls. And so if they're not co-designed and if they're not fit for purpose, they're not going to work. So I think what you can do is think about who are the key people across your organization that you want to hear from. You don't want to over consult, whilst we absolutely do want to consult. What you want to do is take a representative sample. So you will know who the best people to talk to in your organization are. Having really structured focus groups that are, or I should say semi-structured focus groups that look at presenting, here are our key hazards, and we've identified those through, for example, a survey or through a gap analysis. What we want to do now is hear from you around how those hazards are really impacting you, but then move to what do you think would work? What do you think we could do to improve? Who might be involved in that? What would that look like? And then what I would suggest happens is that you take all of that feedback and look at the themes in that feedback essentially. So it might be, for example, that there needs to be some practical steps around reducing occupational violence and aggression. So it might be that there's screens that need to be put up in workplaces, or it might be that there needs to be posters that need to go up around respectful behaviour. It might be that there needs to be training that needs to be rolled out so that people know how to de-escalate situations. So looking at the themes of what your workforce are telling you as to what kinds of things are going to help them to help better control those particular hazards. So it's certainly not a whinge fest of kind of tell us everything that's wrong, but it's tell us about these specific things. We want to know more about them, and we want to hear from you how exactly we can improve your experience of those as well.
Thanks, Krisha. That's great insight. And it really is a lot about making sure that they know that what they're speaking to, there's going to be action followed through with this. There's
Absolutely.
going to be some sort of work done.
Yeah, that's the critical next step as well, is that feedback loop to say, what are we doing with this? How does this feed into our strategy or our actions or next steps? And how are we going to keep you informed of that as well?
Great, thanks, Chris. I'm just mindful of time.
Yes.
And again, we'll share the insights from the polls through the follow-up. And there was one or two other QAs that I think we can do a short form response in the follow-up as well.
Great. Thank you very much, everybody, for joining us today. Have a great rest of the day. Bye for now.
Thank you. Bye.